nerve. The anatomic variations that we see is it can be absent bilaterally, or it can have different origins, such as it can originate from T12 only, or it can have a common origin from T12 and L1, or only L1, or in some cases they have seen originating from T11 and T12 and nothing from the lumbar nerves. So here we see a diagram with a normal lumbar plexus. This is a cadaveric diagram, normal lumbar plexus with psoas major muscle. And this you see after removal of the psoas, the anterior portion, you can see the lumbar plexus here. And this is a picture of post-fixed lumbar plexus. And in the last picture, you can see that the iliohypogastric nerve is absent. The next nerve is ilioinguinal nerve, supplies the muscles mainly of the abdomen, genitalia, and thigh. The anatomic variation is that it can be conjoined with iliohypogastric nerve arising from a common nerve root. Now, next one is the genitofemoral nerve. Usually arises from L1 and L2 nerve roots, but sometimes it can arise or it can divide in the substance of psoas major muscle, or it can divide even before its origin, like at the division at the upper end of the psoas major muscle. The next one is lateral femoral cutaneous nerve. This is the only sensory nerve. There can be an accessory lateral femoral cutaneous nerve present. This accessory lateral cutaneous femoral nerve can be present bilaterally, or it can arise from a different nerve root like L3, L4, L5 in some cases. It can have a varied anatomic course. Usually it crosses the iliacus muscle, it runs towards ASIS, passes below the inguinal ligament, and gives anterior and posterior branch. This is a normal course, but it can have a different course. Like type A, it can run, instead of across iliacus muscle, it can run posterior to ASIS. It can run anterior to ASIS, but even superficial to the sartorius muscle. In type C, it can go medial to ASIS. In type D, it can go medial to sartorius. In type E, it can be embedded in the loose connective tissue. So the anterior branch of LFCN takes part in the patellar plexus and the anterolateral supply of thigh. The posterior branch supplies only the lateral part of the thigh from the greater trochanter to mid-thigh. Femoral nerve is considered as the largest branch of lumbar plexus. It gives branches to most of the muscles of the thigh. The anterior branch supplies to sartorius pectineus, two muscles. Posterior branch supplies to the group of quadriceps femoris. Anterior branch gives origin to two cutaneous nerve, medial and intermediate, which supply the thigh. And posterior branch becomes the saphenous nerve as it goes ahead into the distal part of the leg. Posterior branch of femoral nerve also goes to the knee joint and the hip joint. So mostly the articular branch comes from the posterior branch of femoral nerve. And the sympathetic fibers that supply the vessels like the femoral artery come from the anterior branch. Obturator nerve arises from the lateral border of psoas major. Mostly it enters the obturator foramen, divides into anterior and posterior branches. Anterior branch goes to adductor brevis, longus, magnus, and gracilis muscle. Posterior branch goes to magnus, obturator externus, and in some cases it goes to adductor brevis also. There is a variation such as accessory obturator nerve, which is present. Usually arises from L3, L4. This accessory obturator nerve does not enter the obturator foramen. It supplies mainly the hip joint and pectineus muscle. Now there is a division of the um, obturator nerve into anterior and posterior divisions. So this division can have some anatomic variation. It can divide into the obturator canal as it passes through it. It can divide before it reaches the obturator canal in 10% of cases. It can divide quite distally after entering the thigh in 15% of cases. Usually it arises from L3 and L4. Anterior branch supplies knee joint, posterior branch supplies knee joint, anterior branch supplies the hip joint. This is the cutaneous supply of obturator nerve. As you can see, there are a lot of variations. The most common one is just above the knee on the medial part, 53%. Sometimes it does not supply at all in case of 23%. Remaining patients or the population, you can see nothing near the knee, only the medial thigh is supplied. In some rare cases, it supplies only at the medial knee and nothing in the thigh. Blood supply to the lumbar plexus is complex. The plexus embeds itself in the posterior aspect of the psoas major muscle. And due to this anatomical relation to such a large muscle, it can share its blood supply. The primary blood supply of the plexus comes from the lumbar branch of the iliolumbar artery, which is a branch of the internal iliac artery. And the lumbar plexus has got some protection from ischemic damage due to multiple collateral arterial systems that it receives from small arteries of the psoas muscle. Therefore, ischemic injury to this area, even during complex surgery such as aortoiliac surgery, is quite uncommon. So this is how it looks on Doppler ultrasound. You can see the red area, which is dorsal branch of lumbar. Psoas muscle as a hyperia. Transverse process is seen as hypoechoic area due to the bone. And on the above part, you can see erector spinae muscle. I'll also tell a little about the scanning. We keep the patient in lateral position with the area to be blocked should be up, and you can use a curvilinear probe. We have shown the markings here. The first marking is the PSIS, which we have marked, the iliac crest, and we have marked the spinous processes. We have drawn a continuous line on the spinous processes, and another line parallel to this line around 4 centimeters apart, which is in the sagittal scan. So the first picture is that of a parasagittal scan, and the second picture shows a transverse oblique scan. The patient lies in a lateral decubitus position here. The probe here used here is curvilinear probe. This is how the sagittal scan looks on ultrasound. You can see the transverse processes. You can see the transverse processes as hypoechoic areas. This is the trident sign that you can see here. The trident sign actually it resembles the trident, and the transverse processes are placed in such a way that they look like a trident.
Roma, you can
Hi, sir.
use a pointer.
ठीक है, 1 minute. Trying to, but Sorry, I don't know, somehow it's not showing here. The hypoechoic shadows are the transverse processes. The lumbar plexus is shown by arrow. It is embedded in the muscle, psoas muscle. Muscle is also shown as hyperechoic area. Uh, Two hyperechoic areas coexist in the substance of psoas major. One is lumbar plexus, one is the tendon of psoas muscle, which also looks hyperechoic. But the lumbar plexus is located in the posterior part of psoas muscle. You can see the erector spinae muscle as well above. This is the paramedian transverse oblique scan. Here the psoas muscle is shown on one side, mostly the anterior portion. Lumbar plexus again is seen as hyperechoic areas. You can see inferior vena cava and the vertebral body as well. Here you can see the quadratus lumborum muscle also, some part of it above the psoas major muscle. For lumbar plexus block, the most common method that we use is the shamrock method, which gives an excellent view of the lumbar plexus and the surrounding anatomy. This technique was first described in 2013. The technique is believed to be faster and easier to perform and possibly safer in regards to potential complications compared with other kinds of blocks. So this is a shamrock view. The three leaflets stand for and the stem stands for the shamrock view. One is the psoas. P stands for psoas muscle. Q stands for quadratus lumborum muscle. RS stands for erector spinae, and T stands for transverse process. There's a ventral view and a dorsal view here. So this is how it will look on sonoanatomy. The first picture you see shows the shamrock view. The center portion, the above muscle is QL, erector spinae and psoas to either side, and the stem is the representation of the transverse process. We have also shown a picture of the needle placement and the probe placement so that it becomes easier to understand. And in the last picture, you can see the arrows. The multiple arrows are pointing towards the direction of the needle. So the needle direction has to be perpendicular, absolute perpendicular, and in line with the probe. The other approaches that are there, which have been mentioned in literature, are Vinnie's approach, Shine's approach, Decree's approach, and a Capdevila approach. But the safest and easiest is the shamrock view, and which we use regularly. These are my references. Thank you so much.
Yes, I think that was comprehensive presentation with anatomical variations. Yes, Sangamitra.
Sir?
Yeah. Any questions? Anything?
I would like the fellows to, clear your doubts with Roma ma'am because this is an important topic. So, Dr. Pooja, Dr. Mitali, please go ahead.
How many of you have done lumbar plexus block? Actually, if I may ask. Who are exam going? Pooja,
Yes, sir.
have you done?
No, sir, I have not done. lumbar plexus, but I have seen many cases of lumbar plexus block, like neurostimulation, PNS guided. Uh, Today also I have seen the PNS guided hip.
Could you explain us how it was done with PNS?
Sir, actually, we did it with dual guidance, ultrasound plus PNS guidance. So we marked the highest point of the iliac crest and PSIS and line draw through this. And then at the point of intersection, the needle entered posterior to anterior, and the curvilinear probe was placed above the iliac crest, and then we see the shamrock sign, and we just hit my mentor performed the procedure, and he just hit the transverse process, and then it will go beyond it, and we are able to see the hypoechoic structure within the psoas muscle, like approximately between the posterior one third and the anterior two third, and then we get the quadriceps stimulation, and then we he injected the propivecin 0.2% with cloney.
Yeah. Are you aware what is this technique or the name of technique which he has used?
Sir, it is shamrock technique.
No, no. You have explained the anatomical landmarks also. The intersection of highest point of iliac crest and the PSIS. At that intersection, the needle was inserted. So, what is the name of this approach?
Sir, it is posterior lumbar plexus. Uh,
No, 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 no. Anyone?
Capdevila approach, sir.
yes, yes.
No, no, no. It is not captivilla.
Um,
Roma, could you just show us the last slide? Yes, there, Dr. Roma.
1 minute, I'm showing, yeah. This one?
So, what is difference between Vinny's approach and Capdevilla's approach?
the Vinny's approach is anterior approach. It is inguinal perivascular technique referred as 3-in-1 technique. Uh,
Are you sure? Okay, what is Capdevilla's approach? The most commonly used approach is Capdevilla's approach. Where is the needle entry for Capdevilla's approach?
Sir, it is at medial two third and lateral one third of the line joining the like, midline and point of intersection of the two lines. First, the line drawn superiorly from PSIS, and then
Correct.
intercrystal line between the L4 L5U interspace. And the point of entry is at the medial two third and lateral one third of the line joining the midline and the point of intersection of the above mentioned two
Yeah,
lines.
but in your approach, what you have mentioned, you have inserted the needle at the intersection of intercrystal line and the PSIS line. Then what is this approach? This is not Capdevilla.
Yes, sir.
Are you
Uh,
getting my point?
Sorry, sir.
So what is this name of approach with which you have done block today? Is it either of these four?
It may be Chan.
Okay. Anybody? So I think it's a Vinny's approach. You have to read it. The difference between the Vinny's approach and the Capdevilla's approach is Vinny's has placed his needle little more laterally, and there, like what you did today, and from
Yes.
there you have moved with a little medial tilt so as to reach the plexus. Whereas Capdevilla, what he has done lot of CT guided studies, and after in his approach, he concluded that we need not move needle medially or laterally. We just have to go bang perpendicular. That is the beauty of Capdevilla's approach, and that is why we are safe in Capdevilla's approach. Whereas in Vini's approach, it is at the intersection, what you have mentioned, that highest point of iliac crest and the PSIS line. Now there we have to direct the needle little medially. So
Yes.
there is a problem that it may turn over advertently more medially, and it can cause epidural. Are you getting my point?
Yes, sir. Yes, sir.
Yeah, so that is the possibility with Vini's approach. In that desire to get twitch, we may manipulate the needle little medially. And it
Yes.
is expected also in Vini's approach. We have to turn it little. Whereas in Capdevila, it is medial 2/3, lateral 1/3, intersection point. You have to go bang straight. All right.
Yes, sir.
Now, suppose if you don't get a twitch in that approach, what you will do?
So we should not go beyond 2.2 centimeter beyond the transverse process. And if you don't,
Yeah, beyond 1.5 to 2 centimeter, we should not be going. Correct.
we are getting the hamstring twitch, then we may be in the sacral side, like low, little caudal. So we have to direct it more cranial.
Cranial. Yeah.
Yes. And if we are going more medial, like we did it with ultrasound guidance also. So we are able to see, we were able to see the plexus on sonoanatomy.
Yeah. Um, I would suggest, I would say that it was more of a Capdevila or Vini's approach people tend to do, and they just keep the ultrasound probe there to see what is happening. But a
Yes,
real ultrasound guidance, you need not follow these intersections or lines or anything. You just see
yes,
the target and approach it whichever way you can, it is convenient to you.
yes,
So, usually, if you are doing a Capdevila or Vini, and you are not getting a twitch, we tend to put the probe and we see where the needle has gone. So, once or twice it has happened to me that I could see that needle has gone absolutely laterally. So, we can direct the needle and try and achieve it. So, this is one thing.
yes, sir.
Now, once you get a twitch before injecting the drug, what you should be doing? Is
Uh,
there any precaution?
we
Anybody? Ah,
reduce the current also.
yeah. You got a twitch at 0.5 milliampere, the femoral classical quadricep twitch. What is the essential precaution here before injecting the drug?
Use of color Doppler or negative aspiration for blood.
Yeah, but this is not classical of lumbar plexus. What you are saying is applicable to all the blocks. But if you are doing lumbar plexus block especially, then you are worried about something else. What is that?
So we can increase the current
Hmm.
to 5 milliampere, and if uh, it is getting stimulated, so we might be near the epidural space. So
Okay.
we should reduce. We should not get twitch at higher currents.
True. What is that called?
We test.
Hmm? Pardon
So we
me?
test.
Sweet test. Where else you utilize this sweet test? Where we want to use sweet test to
We
identify
have
whether
Paravertebral catheterization.
Paravertebral. More commonly,
We can use it to confirm the epidural catheter theme, confirmation for the epidural.
yeah. So predominantly we use it for caudal epidural,
Yes, caudal
where there is perianal twitch. So if we
twitch.
get a current in say less than 1.5 milliampere, probably we are intrathecal. Now, if
Yes,
it is up to 5 to 10 milliamp isolated twitch on one side, then probably we are at the in the epidural space. If we are getting it bilaterally, then again probably there is a high chance that we are in the epidural, the intrathecal space. So we should. So what is more important here, which I was trying to highlight, is proximity to the epidural and intrathecal space. And sometimes we may our needle as we are approaching the lumbar plexus may go intrathecal. So before injecting the drug of that 20 ml of local anesthetic, you just have to disconnect and see, allow it, wait if there is any CSF. So putting color Doppler and checking negative for aspiration of blood is perfectly fine. But when it comes to lumbar plexus, I would like to wait and see the hub of the catheter if there is any CSF. Because with aspiration, it may not come with a 10 cc syringe. But if I just allow it to flow on its own in a lateral position, I may see drop by drop CSF coming. So this is very crucial when we inject local anesthetic before the block. All right.
yes, sir.
So most of us probably would use Capdevilla's approach. Of course, I know Diwan sir, he prefers Vinny's approach, but rest all from the AORA community, most of us we use Capdevilla because there is no need to turn medial tilt. You just bang straight, hit the transverse process, go 1.5 to 2 centimeter. If you do not get twitch in Capdevilla's approach, so and if we do not have ultrasound, then what is the first step we should do? नहीं मिल रहा है अभी twitch. So what you will do? Medial 2/3, lateral 1/3, you have gone in, you are hitting the transverse process, you have moved also, you have increased current, everything is right, but there is no twitch. What you will do?
So we will withdraw the needle to the skin level and again redirect it more cranially or caudally, like 5 degrees cranially or caudally.
Yeah, most of us will do that. But here the take home message is when you are not able to get a twitch, take a spirit swab and just clean your slate of all the markings. Probably the markings are incorrect. And redraw it. Take a ruler and again identify the highest point of iliac crest, the spinous process line, the
Mhm.
intersection, the PSIS. Again draw medial 2/3, lateral 1/3, and then proceed. All right. So
Yes,
most
sir.
of the time, the persons who are doing lumbar sacral lumbar plexus block, they will advise you first. If you don't get twitch, the rule of thumb is rub everything, redraw it, and then proceed gradually. Second, before attaching the syringe, always see if there is any drop by drop something is coming, because if you are given that much bolus, then patient will go in shock. Thirdly, as you have pointed out, the Capdevilla's approach is most commonly used approach, and when it is with ultrasound, it is the shamrock view. So when once you get a shamrock leaf and exactly you can see the lumbar plexus, you can directly pass the needle and stimulate it. So it is essentially dual mode because there is no vascular landmark nearby. Otherwise, all the blocks you will have some vascular landmark. Here there is no vascular landmark, all bony landmark. So we have to depend. So lumbar plexus is present within the substance of psoas muscle. Again, it is medial two-third. Sorry, the anterior and posterior. So anterior two-third and posterior one-third. So that big belly of psoas, it is in between. So my question is, how will you identify lumbar plexus on ultrasound? How does it look? Anyone? How will you identify? Is it seen like a subclavian perivascular brachial plexus or something else? Pooja, how was it looking when you have seen?
Sir, it was hypoechoic, uh, fibrillar, and hypoechoic.
Yes, correct. So it is at the junction of anterior
Anterior
two-third and
two-third and
posterior.
posterior one-third of the psoas muscle.
Correct. And you see those white strands, the hyperechoic strands,
Yes,
white, I would say, lines.
yes.
But what it can be else? What is the closest differential diagnosis? When you think that it is lumbar plexus, but it is not, then what it can be?
Maybe the nerve roots coming, the ventral nerve roots, we may confuse with it.
No. The most important point here is there are tendons of psoas muscle within its substance. Are you getting my point?
Yes, sir.
Tendons within the substance of psoas muscle. And tendon, as you can see, are seen as hyperechoic white lines.
Yes,
Sometimes presence of intramuscular tendons can be confused as lumbar plexus. So even though we see those white lines, we are not able to get a twitch. Probably we are stimulating tendons. And these are not the lumbar plexus elements. All
yes,
right.
sir. Yes.
So just for completion's sake, you have told me the approach is Capdevilla's approach for lumbar plexus. What is the name of approach for sacral plexus?
It is, I think,
Hmm?
parasacral block of Mansour.
Mansoor's,
Yes,
yes,
it is the line drawn superiorly from the PSI, sorry, inferiorly from the PSIS towards the ischial tuberosity,
correct.
and 6 centimeter from the PSIS. The point of entry is 6 centimeter from the PSIS on that line.
Yes, what you are saying is right. Or you can say upper one third, lower two third. But more appropriate description is 6 centimeter below from the PSIS, 6 to 7 centimeters below, along the line joining from PSIS to ischial tuberosity. Correct. So, what is the indication for lumbar plexus? Like, why you have given today? Or,
So today was hip debridement.
hmm,
Usually we don't give for hip lumbar plexus for hip,
hmm.
but sometimes we are doing it like to learn and
All right. So, what is the advantage and disadvantage of lumbar plexus versus other blocks which are available for hip analgesia? Is it better, inferior?
for hip we are giving other combination of other blocks
Hmm.
like Peng CFE or sometimes Peng LESP,
Correct,
then Peng and
correct,
posterior QL.
correct.
So we are preferring those instead of touching the lumbar plexus.
Hmm. Why?
So there is less chances of injury, nerve injury, and These are facial plane blocks also, like
Hmm.
ASP, PANG, and CFI.
Hmm. So what is your rationale of choosing blocks for hip analgesia? When you would like to use lumbar plexus, when you would like to use CFI, PENG, LFCN, or posterior QLESP?
Actually, we are comparing three groups. That's why we are giving three. But I prefer CFI and PANG.
No, no. I
Okay.
may prefer anything.
Versus lumbar plexus. Okay.
What is your choice? Somebody would say lumbar plexus ही better है, सब cover हो रहा है. Why not give lumbar plexus?
Hmm.
Better quality of analgesia. I will use 0.2% ropivacaine. What is the problem? Anything why we are choosing some block versus this block? What is your rationale? Study is okay, but
Yeah.
you should have some choice for
Yes.
selecting blocks. Yeah. So what is your choice? Why?
Sorry, sir. I
Okay. Any point you can think of. So I'll give you different points. One, I would say, because this is what we expect you to answer in exam also. First
yes,
thing
sir.
you can say level 1 block, level 3 block,
Yes.
superficial block, deep block,
Yes.
easy block, difficult block.
Yes.
Is this not a logical discussion? Isn't it?
Yes, sir. Yes, sir.
So you can always say, I will do maybe say peng block because it is easy to give, or CFI
Yes,
block
sir.
because it is easy. Lumbar plexus needs training. It's a level 3 block. Okay. What can be
Yes.
the second reason?
In anticoagulated patients, we will not prefer lumbar plexus blocks, sir.
Correct.
But we can go for superficial blocks
Correct.
like
Other
Chelsea
than
or
lumbar plexus, which block comes under deep block?
paravertebral, sir.
No, 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 no. I'm talking of hip only.
QL block.
Sacral nerve.
Quadratus lumborum.
No. Quadratus also, yes.
Yes.
Anterior QL will
And,
not give. Anything
and
else?
for hip, we are normally using neuraxial blocks. So neuraxial procedures will come
Correct. Anything else?
for deeper blocks.
Any other block? Hip block, which is a deep block. As per European Society 2022 guidelines, where they have divided superficial block and deep block. Okay. Is PENG coming under superficial only? What is, because they have included lateral infraclavicular as deep block. They have included quadratus lumborum, paravertebral, central neuroaxial.
Peng is in deep group,
PANG
sir.
is deep.
Deep
Yes,
now.
sir.
Deep.
PANG is in
Yes.
deep block group.
Deep, no?
Peng block.
So
Yes.
don't forget.
Sciatic block.
Yeah,
Also.
so you cannot give a PENG block in an
Yes.
anticoagulated patient. All right.
Yes,
So
sir.
when it comes to hip, I would think of three blocks which I would not like to use. One is lumbar plexus, central neuroaxial, anterior QL, and PENG because these are all deep. So what I am left with is probably LFC and CFI, maybe femoral subpectineal obturator, something
Yes.
like that. All right. So this is our third reason, anticoagulation. What could be the fourth reason? When to use a nerve plexus block versus an interfacial pain block?
For analgesia and anesthesia purpose, sir. For surgical anesthesia, if
No,
we
no, no.
cannot use
I'm
interfacial
asking,
pain.
yeah, surgical is okay, but now we are talking about analgesic block. In that case, whether you would like to use, what could be the reason why people are using femoral subpectineal obturator versus CFI?
Sir, motor sparing.
Yes. So this is
Early
one
motor.
good reason where you can say that we are in the era of Site-specific procedure,
Site-specific,
mainly
procedure-specific, and motor sparing.
motor sparing. So the fourth reason for choice of your block is it should be motor sparing. So first, what 4 points can you tell me what we have discussed? How we
Level
yes, level.
level 1, 2, 3 blocks, and superficial and deep blocks, and difficult and easy for as a novice, difficult and easy blocks. Then in anticoagulant patients on anticoagulant therapy, then for surgical anesthesia and analgesia, and motor sparing blocks.
Yeah, correct. Now, if somebody is doing, say, megaprosthesis, what is your choice of block? Would you use a motor sparing or a motor paralyzing? So
Motor
this is the
paralyzing
why motor paralyzing?
because usually these megaprosthesis patients they will not allow mobilization for initial few days,
Correct. So there is role
and
of
they want complete paralysis for the um, early recovery and for reducing the systemic inflammatory response or stress response. They want the patient immobilization for quite a few
yeah.
days.
So there are surgeries which are like redo surgeries, megaprosthesis, complex hip surgeries, where instead of muscle splitting incision, there are muscle cutting incision, and it creates long duration surgeries, lot of soreness in the muscle. So to control that, we need sometimes muscle paralyzing block, because if muscle is cut, then we have to address that myotome also. Otherwise, only hip analgesia will not cover the soreness of muscle around, and patient will continue to have pain. So my fifth point for choice of block, though I am in favor of muscle sparing block, but there are some surgeries, so procedure specific indications where muscle is cut, long duration or lot of retraction, muscle soreness. In those cases, I need to take care of that muscle pain also. So I would like to have the quadratus lumbo, the femoral, the quadricep little bit, paralyzed, or adductors paralyzed. So a subpectineal obturator or a femoral will take care of major soreness in that area. Is it not?
Yes.
Yeah.
Yes, sir.
So that can be one of the indication. Now, somebody has said that surgery, they are around the hip joint, and incision somewhere is around the lateral aspect. So, what should be my strategy? Is only SIFI or only PENG enough to cover
Lateral cutaneous
analgesia?
femoral nerve should
Hmm?
also be addressed.
Pardon me?
Lateral femoral nerve,
Okay. So, if we understand the complexity, single block is not enough.
Yes.
What should be the combination strategy?
We
Only
can give
hmm.
SIFI with subpectineal obturator nerve block.
Yes.
Like SIFI will cover the LFCN and the femoral nerve, or it may cover obturator if we give more volume. And
Hmm.
also we can block obturator nerve subpectineal.
Yes. That's really nice answer. Correct. What you're saying is absolutely agreeable. And everyone, please make note of it. Similarly, if I am using the other one, PENG, then
Yes. So with PENG, we will cover only the articular branches of accessory obturator and femoral.
hmm,
So for LFCN, we have to give an LFCN block.
yes, nice. So whenever you want to give SIFI, it has to be combined with subpectineal obturator.
Obturator now. Yes.
And when you want to give PENG, it has to be combined with
Like
LFCN.
LFCN.
Now, if I want to do a muscle paralyzing strategy, which block is better?
Femoral with
Femoral.
obturator with LFC answer.
Yes,
Yes, correct. So femoral with subpectineal obturator. Why subpectineal obturator?
because at that level, obturator nerve is not divided into the two, like anterior division and posterior. It is a single nerve.
Yeah,
In
and probably
pectineal, sorry.
Articular branches will not get spared if we give it
Yes,
subpectineal obturator. So
correct. So that is the reason. But I think we are talking about lumbar plexus. So nobody has said lumbar plexus. I think that is also a wonderful strategy if we are planning for a muscle paralyzing block.
yes, sir.
Is it not?
Yes, sir.
So a single block like lumbar plexus block will suffice for a muscle paralyzing, and we can even place a catheter. Has anybody seen or placed a catheter in lumbar plexus?
No, sir.
Okay. So if we place a catheter, it should be 5 centimeter beyond the needle tip for lower limb and 3 centimeter beyond the needle tip for upper limb. So we can place a catheter there. We have placed it in some, these type of redo or complex hip surgeries and all that. So that way. So most important question here is how much volume you would like to give for lumbar plexus block. If it is for surgical anesthesia, if it is for post-op analgesia. Anyone?
25 ml, 20 to 25 ml for analgesia.
Of how much concentration?
So today we give 0.2% ropivacaine and clonine, 20 ml. But we can use 20 to 25 ml.
All right. No, fairly good enough. I think probably because of the vascularity, some people may like to consider addition of little locks with adrenaline as a vascular marker, or nowadays people use fentanyl also as a vascular marker. uh, or you just little adrenalized solution is a good idea, but I think this is quite good enough. I mean, aspirate, inject, do it very slowly, and 0.2 percentage ropivacaine with or without adrenaline, I think it will produce good analgesia. Okay.
Yes.
How will you assess that your block is complete after giving lumbar plexus block? How will you assess that it has acted?
Quadriceps strength. We'll check the quadriceps strength by asking patient to flex the knee.
Flex or
Uh,
extend? Is it knee flexion or extension? What is
no,
the action?
extension.
Extension.
Extension. Sorry, sir. Extension.
And the
Roma ma'am, you can go ahead with your presentation.
You can do very safely with obese patients also. And sometimes these are the severe blocks, and you can do it very effectively. So थोड़ा सा डर के आगे जीत है. This type of block is this. Those who are not very, those who have started their career in regional anesthesia may be little apprehensive with this block, but you should see with those of your mentors or request your mentors to do this block, and I'm sure you can utilize it. बट आई एम नॉट ऑफ द ओपिनियन कि आपका एक फुट डिब्राइडमेंट है और उसके लिए आप लंबर प्लेक्सस दे रहे हैं, बिकॉज एवरीथिंग कम्स विथ अ कॉस्ट. आपका कॉम्प्लिकेशन हुआ नहीं है, इसका लिए ज़रूरत नहीं है कि नॉट एवरी टाइम यू विल नॉट हैव एनी कॉम्प्लिकेशन. सो it should be justified. I mean, once or twice just for twitch elicitation or with point 0.2 ropivacaine, no problem. But I think we should not utilize this as a, you should respect our patients, because during my fellowship, I have seen some of the fellows, they are doing lumbar and sacral plexus block for foot debridement just because they have not practiced it. I think this is barbaric behavior. We should not be doing it. So usually be patient. Time will come. There will be patients who are needy for this block, and do not sell this block because this block has complication. Surgeon has to purchase it. I have done this block, I think, several times. So, and most of them were high risk patients, and the surgeons have accepted all the risk, and they said, you please do it. And we have explained everything to the patient. Patient said, you please do it. And I have done these blocks. What has happened is surgery has gone well. We have started with a dash of NORAD, maintained fluid and hemodynamics. Patient have done the surgery. During surgery, surgeons are really not happy with this because the relaxation is not as good as spinal, and you have to train your surgeon, because when they remove the the femoral head from the socket, they are not happy. So they need more force, because all the adductors, all those muscles do have a lot of strength. They do not paralyze as that of a spinal. So you have to train your surgeons. This blocks works well in a thin lean geriatric patient, little chubby patient and young patient. They do have good background tone. But once or twice where there are indications because of cardiac issues or something, you can definitely use it. And I mean, so what I was trying to highlight is, do not sell this block. Surgeon and patient has to purchase it. So find appropriate patient where you really this block is worth doing it, and it is rewarding. And do develop that courage to put catheter also. We are putting catheters. I have done it, and catheter is another one step 6, where you are well versed and comfortable by putting catheters also, and it really works well. So uh, I mean, if you are a regional anesthetist, I mean, you should reach this level where you are doing lumbar plexus catheters. In pediatric patients, especially teenagers, anatomy is wonderfully seen. Do scan all those 7 8 year old bachus where you will see the anatomy very well, and you can use PNS and stimulate each and every component. If needle moves medially, laterally, if it is goes caudad, all those, so you will pick up all that. And anatomical variations already been described. So once in a while you will not get twitch, it's okay. So be ready for whatever is needed. But I think this is not a very difficult block, and there are surgeons, there are anesthetists. One is Dr. Sandeep Diwan, and internationally, I could see, I can remember from Germany, Paul Kessler. He has done thousands of blocks, lumbar plexus, and he is using it regularly for all hip surgeries with or without catheters. So it is safe, and use it, and you can train others also.
I
Yes.
at least scanning each and every patient. If don't get a block, but at least scan whenever it's possible. If you're putting the patient lateral, if you have some time, at least scan for lumbar plexus. Have a habit of using USG and just scanning for any of the blocks that you, not necessarily go through the needle, but scan, identify the structures. So once you get the image, sono anatomy, the next time, again, I agree with sir completely. Don't try to venture in things alone when you're just starting with blocks. Get your mentor with you. First scan 2-3 times. With your mentor again 3-4 times under his guidance. Then probably I guess you should try for lumbar plexus. Because the effect that gives you in a very indicated patient is amazing. It is a rescue block in a case where you cannot give anything but a lumbar plexus. But it comes with a caution of be thorough in your anatomy. Scan, so you should have a good sono anatomy and your mentor teaching you at least 2 to 3 times before you start doing it.
Yes, thank you. Correct. So, if no more questions, over to Sangamitra. Yeah.
Thank you, sir. Any other queries from the fellows? So thank you, Roma ma'am, for your excellent presentation, and Amit sir for continuing the baton. Dr. Prachi madam for the wonderful inputs and sharing the image on the WhatsApp group. We will continue our next session of sacral plexus block with team Sancheti next week. And thank you all for joining today. And I will upload the recording tomorrow morning. Keep reading. Thank you so much.
Thank you,
Thank you.
Sangamitra.
Thank you,
Thank you,
sir.
ma'am. Thank you,
Good
Amit
night.
sir. Thank you. Leave कर रही हूँ.